Warm good afternoon to all our viewers here from Geriatrics hospitals. On the eve of World Cancers Day tomorrow, February 4th, we have this exclusively live chat. We have with us here Dr. Rejiv Rajendranath, who is a senior medical oncologist with us. With him, I am Dr. Magesh, Geriatrician. We are here to initially discuss common myths and doubts in cancers in the elderly. Because we have a varied audience, we will be using both English and Tamil in this discussion. So, அனைவருக்கும் ஜெரிகேர் முதியோர் நல மருத்துவமனையிலிருந்து அன்பான வணக்கங்கள். வேர்ல்ட் புற்றுநோய் தினத்தை ஒன்று நாளைக்கு February 4th அதுக்காக இன்னைக்கு இந்த ஸ்பெஷல் ப்ரோக்ராம் பண்ணுறோம். புற்றுநோய் சம்மந்தப்பட்ட டவுட்ஸ் இல்லை ஸ்பெஷல் கொஷின்ஸ் எடுக்கிறதுக்காக இந்த ஒரு லைவ் டிஸ்கஷன் நடக்குது. டாக்டர் ரஜீவ் சீனியர் மெடிக்கல் ஆன்காலஜிஸ்ட் நம்மோடு இருக்கிறாரு. நான் டாக்டர் மகேஷ். பொதுவாக ஏஜிங் வயசாகிறது முதுமை வந்து ரொம்ப காமன் ஆகிடுச்சு. இப்போ நம்ம நாட்டில் இண்டிபெண்டன்ஸ் சுதந்திரம் அப்போது லைஃப் எக்ஸ்பெக்டன்சி வந்து 50 வயசு பக்கம்தான் இருக்குது பொதுவாக. இப்போ பார்த்தீங்கன்னா 70 வயசு தாண்டிடுச்சு. ஸோ எல்லாருமே ரொம்ப மக்கள் வந்து அதிக ஆயுளுடன் வாழ்கிறாங்க. ஸோ இதோட என்ன ஆகுதுன்னா இதோட ஹெல்த் ப்ராப்ளம்ஸும் கொஞ்சம் இன்க்ரீஸ் ஆகுது. அதில் இப்போது நாம் ரொம்ப பார்க்குறது வந்து புற்றுநோய், கேன்சர் என்ற நோய் கொஞ்சம் அதிகமாக இருக்குது. ஸோ டாக்டர் ராஜீவ், ஐ லைக் டு இன்வைட், கேன் யூ டெல் அஸ் அபவுட் திஸ் cancers in India and in the elderly?
Good afternoon, viewers. So as Dr. Magesh correctly put it, we are here to discuss about cancer in the elderly on the occasion of World Cancer Day. உங்களுக்கெல்லாம் தெரிஞ்ச மாதிரி வேர்ல்ட் கேன்சர் டே வந்து யூனியன் ஆஃப் இன்டர்நேஷனல் ஃபெடரேஷன் அகெயின்ஸ்ட் கேன்சர் UICC every year they conduct, and the main theme is to close the care gap. That means எங்கெல்லாம் கேரில் கொஞ்சம் challenges irko, we will try to manage it. So that was the whole idea in bringing this program together, to have close the care gap mainly of managing the cancer in the elderly. As sir rightly pointed out, cancer in the elderly, vayasanavarakku varudha putrunoi is becoming more challenging, and there is a general trend that we are seeing more and more older patients with cancer. Again, as Dr. Magesh told, more and more when our life expectancy is increasing, especially in a country like India, the chance of incidence of cancers also increase. In other words, it is because of the aging process itself that we see many of the cancers like breast cancer in the ladies, prostate cancer in gentlemen who cross around 60 or 65 years. So aging itself is one of the cause for increased incidence in cancer. And of course, we have increased awareness and more people come forward to diagnose, because 20 years munadiyela pathina many people die, especially in the second tier, third tier cities, without a diagnosis, and we won't even know that a cancer existed. But now all the cities are getting more and more advanced in diagnosis and early detection. So we are seeing more and more cancers diagnosed in the elderly. And of course, other known factors like smoking, alcohol consumption, pollution in the environment, food habits, all those also will contribute to increased cancers in the elderly.
So I think அதிக awareness ஓரளவுக்கு இருக்கு.
Yes.
People are also coming forward for testing.
Yes.
அதனால அதுவும் ஒரு காரணமா இருக்கு. So கேன்சர்ன்றது எப்பவுமே இருந்திருக்கு, பட் இப்போ கொஞ்சம் வயசானவங்க அதிகமா இருக்கிறது, and awareness for people and people coming forth for testing is increasing.
Absolutely, yes.
Very nicely said, doctor. So that is an important point, because as a geriatrician, முதியோர் நலத்தில் இருக்கிறதுனால நான் 15 வருஷமா ரொம்ப பேருக்கு வந்து இந்த டெஸ்டிங் பண்ணிக்கிறதுக்கே வந்து ஒரு ஹெசிடேஷன். ஏன்னா எனக்கு வயசாயிடுச்சு, ஐ எம் ஓல்டர் ஆல்ரெடி, ஸோ திஸ் சிம்டம்ஸ் ஐ அக்செப்ட் அஸ் ஏஜிங் பிகாஸ் ஆஃப் ஏஜிங் அப்படின்னு. ஸோ சம்டைம்ஸ் இட் இஸ் சேட். ஐ திங்க் பல மாதங்களாக சில அறிகுறிகள் இருந்தும் கவனிக்க டெஸ்ட் பண்ணாமல் விட்டுடுறாங்க. அண்ட் not because of any fault of theirs, it is just their misconception. This is a very important point as a geriatrician I see, because கொஞ்சம் ஒரு 3 months முன்னாடியோ இல்லை 1 month முன்னாடியோ வந்திருந்தா, the cancer specialist also says that we could have made a big or better difference. So in the late presentation in elderly ஒரு பெரிய சேலஞ்சாக இருக்குது, ஒரு ப்ராப்ளமாக இருக்குது. ஸோ ஏதாவது some guidance when you see as an oncologist, anything, any particular symptom you are wanting to tell us which we should people should be aware of, that they should consult their doctor?
So as Dr. Magesh will know, we discuss in our meetings itself that age is just a number. So we need not go by age aanadinala, we should not deny them any of the screening test or early detection other. So we'll have to look at it as a multidisciplinary approach and see that we need to assess the longevity. For example, we would have seen excellent general condition patients who are 70-75 years but very frail 60 years. So we cannot generalize age only as a number. And as you rightly put, like in cancers of any age, earlier the detection of cancer, easier it is to treat and diagnose, and more importantly the cure rates will be much more. So the same thing holds with the elderly also. So as we keep telling that age cannot be the only factor where we deny a master health checkup or cancer detection, because நிறைய வாட்டி என்னன்னா அது ஒரு நிஹிலிசம் மாதிரி ஆயிடுது. வயசாயிடுச்சு, இனி இதுக்கு இந்த டெஸ்ட் எல்லாம் பண்ணணும், இது எனிவே கொஞ்ச நாள் தான் இருக்க போகுது, இதுக்கு இந்த டெஸ்ட் பண்ணணும். ஸோ அந்த மாதிரி ஒரு நிஹிலிசம் இருக்கக்கூடாது. And as we discuss in our meeting, it should not be over enthusiasm also. ரொம்ப வயசான ஒரு end stage kidney disease இருக்கிறதுக்கு போய் mammogram எல்லாம் பண்ணி early detection we should not. So it should be a fine balance where we should be looking at screening programs, especially designed for elderly. At least once in 6 months we should come up, elders in our family has to come for a health checkup, where we have designed for specific tests to detect cancers also, which are can be detected early. That said, not all cancers can be detected early by screening. So there are some cancers called screen detected cancers which can make a difference. For example, breast cancer வந்து மார்பக புற்றுநோய் வந்து நம்ம ஏர்லி ஸ்டேஜில் அந்த தொற்று பார்க்காத முன்னாடி ஸ்டேஜ்லேயே மேமோகிராம் மூலமாக கண்டுபிடிச்சிச்சுன்னா சின்ன பயாப்சி பண்ணி மேபி சர்ஜரி அலோன் ஆர் சர்ஜரி ப்ளஸ் சம் ஹார்மோனல் ட்ராப்லெட்டில் we can complete the entire treatment. அதே வந்து கொஞ்சம் பெருசாகி நீர்க்கட்டியில் எல்லாம் ஸ்ப்ரெட் ஆகிடுச்சுன்னா then we may require surgery, ஃபுல்லாக மார்பக எடுக்க வேண்டியது இருக்கும், கீமோதெரப்பி, ரேடியேஷன் எல்லாமே தேவைப்படும். ஸோ ஏர்லி டிடெக்ஷன் இஸ் த கீ, but in elderly we need to balance out where the screening test will benefit them the most. And as a geriatrician you would also be much more judgmental in knowing which patients will benefit. That's what I wanted to ask you. We tell that pediatric na adukku pediatric oncology irukku, ladies na women's there is gynecology and gynec-oncology. So this is a new specialty where geriatric oncology, வயசானவருக்கு கேன்சர் வந்தா geriatrician oncologist சேர்ந்து ஒரு multidisciplinary team we form and try to treat. So as a geriatrician, what do you think it helps by forming a geriatric oncology team? How does it help a patient elderly with cancer?
I think pertinent. In Geriatrics hospital we have a multidisciplinary team, geriatrician with medical oncologist, surgical oncologist, psychologist, dietitian. So இது வந்து ஒரு டீமா பேஷண்ட் அசஸ் பண்ணுறது ரொம்ப முக்கியமாக இருக்குது. ஓல்ட் ஏஜ் கேன்சர்ஸ் ஜீரியாட்ரிக் ஆங்காலஜி இஸ் ஸ்பெஷாலிட்டி. சில கண்ட்ரீஸில் ஆங்கோ ஜீரியாட்ரிக்ஸ்னு கூட இருக்குது. யூகே, யூரோப், அயல்நாடுலாம் இது நல்லா டெவலப் ஆகிட்டு வருது லாஸ்ட் ஃபியூ இயர்ஸாக. அண்ட் அதற்கேற்ற ரிசர்ச் ஸ்டடீஸ் அண்ட் ஃபர்தர் நாலேஜ் வந்துட்டுருக்கு. And we in Gericare are also following the same model, and we are when we are dealing with a elderly person with malignancy, we discuss and right from assessment. நம்ம assessment பண்ணுற போதே வந்து geriatrician inputs are taken into account. இதில் older person with cancer, as you know, Dr. Rejiv, multiple systems functioning. I mean, already you pointed out about how age மட்டுமே வச்சு ஒரு பர்சனோட capabilities, functional capacity டிசைட் பண்ண முடியாது. ஸோ மல்டிபிள் டொமைன்ஸ், அவங்களோட மனநிலை எப்படி இருக்குது, அவங்களோட மெமரி எப்படி இருக்குது, ரைட் ஃப்ரம் த பிரெயின் டு கிட்னி ஃபங்க்ஷன், ஹார்ட் ஃபங்க்ஷன், லங் ஃபங்க்ஷன், அண்ட் அவங்களோட டெய்லி ஆக்டிவிட்டிஸ், அவங்க வேலைகளை அவங்களால செய்ய முடியுதா, என்ன இதில் குறை இருக்குது. இப்போது கேன்சர் டயக்னோசிஸ் இருக்குன்ற பட்சத்தில் ட்ரீட்மெண்ட்டோட வாய்ப்பு மற்ற சிஸ்டத்தில் எப்படி இருக்கும், அந்த பர்டிகுலர் எல்லாமே இண்டிவிஜுவல் வயசானவருக்கு எப்படி வந்து இந்த ட்ரீட்மெண்ட் வந்து மற்ற சிஸ்டத்தை ஆல்டர் பண்ணுன்றதுனால இந்த ஜிரியாட்ரிக் எவாலுவேஷன், நம்ம வந்து ஜிரியாட்ரிக்ஸில் காம்ப்ரிஹென்சிவ் ஜிரியாட்ரிக் அசஸ்மெண்ட்னு சொல்லுவோம். ஸோ ஒரு ஃபுல் அசஸ்மெண்ட் ஆஃப் த மைண்ட், பாடி அண்ட் இஸ் ஃபங்க்ஷனல் கெப்பாசிட்டி, ஃபங்க்ஷனல் எபிலிட்டிஸ் பண்ணுவோம். ஸோ அதில் என்னென்ன வீக் ஏரியாஸ் ஒரு வல்லரபிள் ஏரியாஸ் இருக்கோ we have to identify. அதுதான் the role of the geriatrician in an oncogeriatric unit or multidisciplinary team. ஸோ இதுலேயே வந்து we are able to find out hidden problems.
Yes.
Like for cancer, மற்ற system problems வந்து sometimes they are not aware that the problem exists. So we pick up other small or new problems, but அது வந்து treatment பொறுத்தவரைக்கும் சிக்னிஃபிகண்ட்டாக இருக்கும். ஏன்னா நம்ம கேன்சர் ட்ரீட்மெண்ட்டுக்கு போகும்போது இந்த சிஸ்டம் டீஸ்டெபிளைஸ் ஆகிறதுக்கு வாய்ப்பு அதிகமாக இருக்கும்னு we will find out. ஸோ அது ரொம்ப காமனாக பார்க்குறோம். ஸோ அதை ப்ரிடிக்ட் பண்ணி அசஸ்மெண்ட்டில் அதை எப்படி டேக்கிள் பண்ணுறது, how to prevent that system from destabilizing. For example, somebody might be already having silent kidney disease.
Yes.
That test we find out, and we will then try to see if there is a medical reason for that. அதை டேக்கிள் பண்ணும். அதே மாதிரி நம்ம மெடிசன்ஸ் கொடுக்கும்போது ஃபார் த ட்ரீட்மெண்ட் ஆஃப் கேன்சர் கிட்னியோட ஃபங்க்ஷனை எப்படி மானிட்டர் பண்ணணும், எப்படி பாதுகாக்கணும். ஸோ இந்த ஒரு ப்ரிவென்டிவ் அப்ரோச் we are able to take in the comprehensive assessment of the older person with cancer. So the CGA or the assessment becomes very important, and working as a team and following the treatment plans as a team is very important in the older person with cancer.
I think as you rightly told, we have seen 60-year-old patient with lot of comorbidities like hypertension, diabetes, heart disease, then we cannot treat them very aggressively with cancer. On the other hand, 85-year-old gentleman we have seen with excellent general condition with absolutely no problem playing tennis, and then we treat them very aggressively. So as you rightly put it, it's objectively we should assess as a team comprehensive geriatric assessment, and that will help us objectively plan the treatment, like how much in the future a person will tolerate our cancer treatment, which are also not very friendly. In the same way, I want to ask Dr. Magesh, most of the time when they come for the first time, even with diagnosed with cancer, they come with a whole box of, and the caregiver, they are also confused when they are diagnosed with cancer. So can you brief on that, please?
Very, very important question, Dr. Rejiv. I think polypharmacy என்றது எக்கச்சக்கமான மருந்துகள் இருக்கிறது. அது 2-3 பிரச்சனைகள் இருக்கிறது வந்து கொஞ்சம் காமனாக இருக்கலாம். ஸோ ஒரு 3-4 ப்ராப்ளம் இருக்கிறது கொஞ்சம் காமன் எல்லி பர்சன்ட். ஸோ இதனால வந்து நம்ம ஊரில் இந்தியாவில் வந்து 2-3 ஸ்பெஷலிஸ்ட் பார்க்குறதுனால மெடிசன்ஸ் வந்து கொஞ்சம் அதிகமாகிடும். அந்தந்த ஸ்பெஷாலிட்டிக்கு ஏற்ற மெடிசன்ஸ் அவங்க கொடுப்பாங்க. பட் இந்த மெடிசன்ஸ் ஆர் வெரி இம்பார்ட்டன்ட்ன்றது ஃபஸ்ட்டு பார்க்குறோம். இது வந்து ஒரு காமன் அப்ரோச் ஆஸ் எ ஜெரியாட்ரிஷியன் இன் throughout the world, Western country out India out. But India, one common problem related to polypharmacy is medicine mistakes or errors. Cardiologist பார்க்கும்போது diabetology prescription or medicines நம்ம பேஷண்ட்ஸ் அங்கே எடுத்துகிட்டு போயிருக்காங்க. ஸோ அவர் வந்து கொஞ்சம் diabetic protection சேர்த்து மெடிசன்ஸ் கொடுத்துருக்காரு. whereas diabetologistum cardiac protection சேர்த்து மெடிசன்ஸ் கொடுத்துருக்காங்க. ஸோ what happens is double medications. ரொம்ப கொஞ்சம் இட் இஸ் நாட் அன்காமன் பார்க்குறோம். 2 மெடிசன்ஸ் சேம் மெடிசன்ஸ் பிகாஸ் போய் ஃபார்மசிஸ்ட் கிட்ட ப்ரிஸ்கிரிப்ஷன் கொடுத்தா இட் இஸ் கிவன். Whereas Western countries the problem identified பண்ணி elderly care important component is the medication error also. So இது வந்து நம்ம when we are doing our geriatric assessment, most of us spend time to kind of look at the pill bag. So முக்கியமாக prescription மாத்திரம் இல்லாமல் அவங்களோட மருந்துகள்லாம் எடுத்து வர சொல்கிறாங்க வீட்டில் இருக்குது. அதுலேயே வந்து we are able to clearly identify what are the medication errors, polypharmacy. That is one type of medication error. Other is too many medicines. Typically definition வந்து 5 to 8 medicines இருக்குது. But பொதுமக்களுக்கு சொல்லணும்னா அதுக்கும் ஒரு விஞ்ஞானம் இருக்குது. அதாவது முதியோருக்கு வந்து இத்தனை மெடிசின்ஸ் இருக்கும்போது சில மெடிசின்ஸ் லெஸ் எஃபெக்டிவ் அந்த பல்மனாலஜிஸ்ட் நாங்கள் நிறுத்த போகிறது. அதில் சில மெடிசின்ஸ் வந்து செகண்ட் இம்பார்ட்டன்ஸ். ஸோ அதை வித்ஹோல்ட் பண்ணுறச்ச the body's need or handling of number of medicines is better. So என்ன medicines சாப்பிட்டாலும் finally the body has to. So we are going to give life-saving drug disease interactions. இந்த மெடிசன் இருக்கிறதுனால இன்னொரு டிசீஸ் டீஸ்டெபிலைஸ் ஆகும். எக்ஸாம்பிள் நம்ம புரியுற மாதிரி சொல்லணும்னா யூஸ்வலி இந்த டயபெட்டிக் மெடிசின்ஸ் கண்ட்ரோல் இல்லைன்னா இன்னொரு 2-3 மெடிசின்ஸ் இருக்கிற மாதிரி இருக்கும் டயபெட்டிக் மெடிசின்ஸ். அண்ட் when we are going for cancer treatment, people's intake reduces and their whatever frailty also becomes a little bit compromised for a few days. So the potency of the sugar medicines increases and our sugar down at low. So we have to consider drug disease interaction and stop or reduce the number of diabetic medicines taken. These are common things. Same with hypertension medicines also we see. So preemptively we do some preventive measures in the older cancer patient to reduce this type of problems so that they get good or reasonable comfort while undergoing treatment for cancer. So polypharmacy and medication errors are a very important issue in the elderly and more so with older person with cancer. And
yeah, I think very well put, Dr. Magesh. So after joining the geriatric oncology team, now I've come to learn more about polypharmacy and rather than prescribing, de-prescribing. நம்ம நிறைய மெடிசின்ஸ்க்கு பதிலாக இந்த எல்லா மெடிசின்ஸும் பார்த்து ஒரு டீமாக உட்கார்ந்து which medicines can be avoided, which medicines may be continued in a newly diagnosed patients with cancer. So that's absolutely essential as a patient as well as enlargement of the breast. So it's a very good question. So vayasanavarikku sometimes there can be pain in the breast, but usually it is during the periods or periods nikkumbodhu dhaan pain varum. So usually painful enlargement of the breast as a dictum is not cancer, but that doesn't mean that pain irundha cancer illannu kediyadhu, but usually it's a painless lump that will be a warning sign for cancer, but either a mammogram. But usually pain in the breast will not be associated with cancer. In the early stages the lumps are usually பண்ண வேண்டிய ஒரு டெஸ்ட். இது வந்து annually பண்ணணும் after 50 years and after 65 years we will have to discuss and make it once in 2 years. So this will detect very small, நம்ம lump தொட்டு பார்க்காம முன்னையே we will call it as a screen detected breast cancer. அதில் அப்படி கண்டுபிடிச்சிங்கன்னா then the chance of curing it with very simple treatment is high. Yes, so breast cancer enlargement is a concern, breast enlargement, but whether it is painful or painless, better to consult your doctor and then take a decision.
Thank you, Dr. Rajiv. I think ஒரு important point நீங்கள் touch பண்ணீங்க about screening. As geriatricians, we encourage older person to have a preventive health check. If not every year, at least once in 2 years to come and அப்போ வந்து we do kind of do a screen for any occult cancer or any family history of malignancy.
Yes.
And particular to India, you highlighted the common cancers in women are breast and kind of uterine cancer, and in men prostate cancer. So is there any set of tests we usually apart from blood test ultrasound பண்ணுவோம்? Is there any set of tests you think the elderly people should undergo and in what frequency to with the aim of நம்ம cancer screening என்ற மாதிரி அதை பற்றி கொஞ்சம் பேச முடியுமா?
So I think Dr. Magesh, that's one of the most important questions of today. So screening பொறுத்த வரைக்கும் we can male and female ladies and gentlemen ரெண்டா பிரிச்சுக்கலாம். So if you take ladies, elderly ladies, we'll take it as above 50 years. Then the common cancers are breast cancer, cervical cancer, lung cancer and colon cancer. So இதில் வந்து we will breast cancer க்கு நான் முன்னாடி சொன்ன மாதிரியே mammogram and a clinical breast examination ideally once a year. And then cervical cancer க்கு வந்து we will have to do once a year. We will have to once a year we will have to check whether it is has to be done with pap smear examination. And colon cancer we will have to do a simple blood test and a fecal occult blood test nu solvom. And for gentlemen again prostate cancer is considered prostate cancer is common, and lung cancer. Lung cancer வந்து it's bit tricky because there is no standard guidelines to use it for all elderly patients, but we need to risk stratify. As a geriatricians, as you will know sir, the most important history we will be taking for lung cancer will be smoking. So if there is a high risk smoking in the patient or in the person who is going to undergo a checkup, it's preferable to do what is called as a low dose CT scan. So CT scan வந்து low dose radiation ஓட பண்ணிட்டு we will have to check for lung cancer. So high risk patients க்கு மட்டும் lung cancer screening, prostate cancer screening preferably by a PSA and a clinical examination above 60 years, and a colon cancer by serum CEA. These are the few practical tips for screening which is tailored to us in Indian population, because in the West, as you told earlier, it's more well organized in the sense that the government makes it mandatory to do some of the screening test. Here it is more of a voluntary, or what we call it as an opportunistic screening. That is, when they come for a regular health checkup, you also tell about the advantages and disadvantages of screening. And again we come back to the earlier discussion where longevity and the geriatric assessment is absolutely essential before we tell about screening, because in somebody who has very little chance of a 10-year longevity or due to other comorbids like end-stage kidney disease or dementia, that is where input from a geriatrician is absolutely essential, because we need to have that much of longevity to get the benefit of a screening test. So we are pretty sure that due to other comorbids like a heart disease or kidney disease, a person is not going to survive beyond 2 or 3 years, then we don't usually advise screening test. So it's a balance again, not to be over enthusiastic, but not also, more importantly, not to be nihilistic, where வயசாயிடுச்சு அதனால இதுக்கு பண்ணணும் அப்படி கிடையாது. So it's a balance. As a team we should meet for screening.
Very important answer, Dr. Rejiv. I think screening is, if there is one message from today's talk, I think it should be on screening for cancer, because early detection and the benefits of early detection and treatment are the one. So as Dr. Rejiv said, it has to be tailored, it has to be targeted for that particular elderly individual based on his functional ability and comorbidities. அவரோட மற்ற நோய்கள், அவரோட உடல், ஒரு எல்டர்லி லேடி அவங்க ஹஸ்பண்ட், நீங்கள் சொன்ன மாதிரி ஆப்பர்ச்சுனிஸ்டிக் ஸ்க்ரீனிங்க்கு ஒரு நல்ல ஒரு எக்ஸாம்பிள் தோணுச்சு. அவங்க ஹஸ்பண்ட் ஐசியூவில் அட்மிட் ஆயிருந்தாங்கன்னு வந்திருந்தாங்க. அண்ட் அங்கே இருக்கிறதுனால அவங்க சில்ட்ரன், சரி நீங்களும் ஒரு ஸ்க்ரீனிங் டெஸ்ட் பண்ணுங்கன்னு சொன்னாங்க. அண்டு அல்ட்ராசவுண்டில் தே ஃபவுண்ட் அவுட் கிட்னி கேன்சர். And the very next day the lady developed bleeding, urine bleeding. So it was very quick incidental detection and in quick surgery. And இப்போ வந்திருக்கிற techniques of surgery, anesthesia and the newer medicines are a big advancement in the medical, I understand, which benefit the elders more because of like bloodless surgery, kind of surgery with minimal invasiveness. ஸோ முன்ன மாதிரி ஃபுல்லாக கட் பண்ணாமல் ஜஸ்ட் ஒரு மினிமல் ஹோலோட கீ ஹோல்லையே வந்து சர்ஜரிஸ், இதெல்லாம் கூட கேன்சர்ஸ்க்கு நவ் இட் இஸ் பிகம் வெரி அவைலபிள். ஸோ அதை பற்றி வாட் ஆர் த கைண்ட் ஆஃப் நியூவர் அட்வான்சஸ் யூ ஃபீல் இன் கேன்சர் விச் ஆர் benefited the elderly much more?
Yes. So again a very relevant question because as elders we will have lot of other comorbid issues like heart disease, hypertension, diabetes along with cancer. So it becomes quite challenging to give them very aggressive treatment for cancer. So that is where the new advancements in all the fields like in surgery, chemotherapy and radiation. These are the three main pillars of treating any type of cancer. So if I take chemotherapy, which I am the specialist, you will know that there are not only the earlier we used to call chemotherapies where there are a lot of side effects, hair loss, low blood counts, infection, bleeding. அது ஏன்னா அந்த drugs வந்து cancer cells ஓட சேர்ந்து regularly in our hospital also we do what is called as molecular testing or personalized care. That means ஒரு patient the tumor எடுத்து we will send them for multiple testing which will help us. Many of these drugs are in tablet form. For example, even if stage 4 lung cancer, if you have a mutation called EGFR mutation, you can just take a tablet at home and visit the hospital maybe one or in a big way in treating elderly with cancer. Last 4-5 years we have got what is called as immunotherapy. Immunotherapy again are medicines where it is a natural way of attacking a cancer cells. We try to boost or allow it's more of a natural way of killing the cancer cell, and that has also come up in a big way in elderly patients with cancer. But the problem or the challenge is immunotherapy is the cost involved. The cost is much more than the chemotherapy, and there again what we as Indians we have as good as a regular dose of immunotherapy. The basic idea is to reduce the cost of treatment so that it can reach to a larger number of patients, especially elders with cancer. So immuno affect only the organ or the area of interest and spare all the normal tissue outside it has come up as a big boon for patients who are suffering with cancer in elderly.
Because the knowledge especially in cancer is exploding at an exponential rate, and when I was a trainee, which goes back 2 decades ago, what was known and taught to us ourselves and what better than இவர்கள் எல்லாமே எக்ஸ்க்ளூட் பண்ணிடுவாங்க, ட்ரீட்மெண்ட் இதில் இருக்க மாட்டாங்க. ஸோ அவங்களுக்கு இந்த ட்ரீட்மெண்ட் எப்படி பொருந்தோன்றது. பட் இப்போ வர கொஞ்சம் ஸ்டடீஸில் அந்த சப்ஜெக்ட்ஸ் சம்டைம்ஸ் வி ஃபீல் ஒரு கேஷுவல் கமெண்ட் by a doctor, sometimes it kind of puts our opinion எடுக்கிறது முக்கியம். ஏன்னா பழைய teachings are now outdated about cancer, many things. So we have to take a very valid opinion from a valid center. ஒரு நல்ல ஒரு
do a screening test once a year. That is highly recommended. So if you are a smoker, the best thing to do is stop smoking or quit smoking, because if you are a smoker, because to convey with this interaction, and of course if we have already smoked for significant number of years, low dose CT scan during your annual health checkup will be advisable.
Okay, doctor, there's one other question here about from Ms. Vidya. How common is brain tumor in senior citizen? Is it necessary to do CT brain when doing master health checkup after a certain age?
So that's Ms. Vidya, that's a very important question, because the general again trend or the thinking when we come for a master health checkup, especially cancer checkup, is at one time we are able to screen all the cancers in the body. That is unfortunately not true. So we are screening only common and screen detected cancers. So we actually go by the statistics which are available with us, like top 5 cancers in male and top 5 cancers in female, and try to screen them. So as I told you, breast cancer, cervical cancer, colon cancer in ladies, and lung cancer, prostate cancer, colon cancer in head and neck cancers in males. So the brain cancer does not come in the top 5 and it is not very common at all. But of course, if somebody who has got brain cancer, then it is very challenging to treat it also. So the basic idea would be in a screening or a master health checkup to take a detailed history and an examination, clinical examination, and if there is any doubt that there is signs of brain tumor like continuous headache or some neurological deficit, then of course we can do a MRI brain. More than the CT, MRI brain is more important to detect, but we would not recommend it as a general screening. So we don't do CT scan brain as a general health checkup, because the incidence of brain cancer is too low.
Thank you. Thank you, Doctor. So while we go to the next question from Dr. A. Sundaramurthy, pulmonologist, is asked, is there an age limit for aggressive treatment for cancer, and is there an alternate word for word cancer which can be used to convince or accept the older patient, geriatric patient? I think I'll try to answer the second part of the question. I think we are culturally different, and I think definitely it raises the anxiety, and people's mood definitely alters significantly when they hear the word cancer. So we all have developed a kind of subtle ways of addressing the patient while we are at their bedside or sitting in the clinic and talking about it. The Western way of addressing is always to try and convince and explain to the patient because they are important decision makers in their treatment. Number country la apdi illa. I think there is a lot of family support, and usually there are family members who are carrying and taking care of their treatment and expenses, and their wish also has to be taken into account. So sometimes I see that they really don't want the patient to know the word cancer and they are having cancer. So as much as possible. But if the patient himself wants to know, because of so many visits to the hospital, yes, tests, and sometimes not knowing actually makes them much more ill and depressed because they fear the worst. இது விட மோசமாக இருக்கணும் இருக்கிற சிச்சுவேஷனோட their mind would imagine it is really worse because people are hiding information. So I think it is very important for all members of the team, especially here in Gericat. We do share the notes for each particular patient on how what is the wish and how to approach this particular patient, and try to address that issue.
So I think his first part of the question was at what age till you aggressively treat cancer. I think we have already discussed that. So age is just a number. So we have had an 85-year-old at Gericare. We have given the standard aggressive treatment for lymphoma, and she is a survivor. But many people with 60-65 itself with kidney disorder and heart disorder, we'll have to discuss with our geriatric team like whether we should treat them at all or we should give them mild treatment. So age is not a cutoff, but a comprehensive geriatric assessment with a complete multidisciplinary team, and then we discuss also with the patient and the family what their expectations are. So it may not be curing the cancer alone, but a quality of life is also very, very important when we are treating elderly patients with cancer, because caregivers are also equally affected. So we see 40 to 50% of the time caregivers also get a lot of stress, and physically and psychologically, because they have to come each time to the hospital. Multiple visits whether can be avoided, and sometimes many of them may be abroad. So all this has to be taken into consideration before we tell that we are going to aggressively treat a patient with cancer in the elderly. The second part, as Dr. Magesh very rightly put, we are culturally different. So like in the West, we cannot tell upright that you have cancer and you are going to die in the next 3-4 months in a patient with advanced cancer. So we take multiple interviews, multiple family consult, and usually the first reaction from the caregiver would be they will say the avarikita solladinga sir. So then we will respect that, and we will have multiple consult. We will also include the primary geriatrician, for whom they will have much more confidence than us in the initial visits. And then as a team, at some point we will disclose to the patient, because as Dr. Magesh told, especially in elderly, there are many things to be taken care of apart from treating cancer optimally. They need to have advanced life care planning done. They need to have, when they are sick, how do they need to be managed, whether they need to be in the hospital or assisted living or home care. All this needs to be discussed at some point of time in the elderly patients with cancer. So it's always mindful for us to respect the family's wishes, but also to keep telling them that the patient should know at some point of time so that they'll be able to take informed decision. Surprisingly, many patients with elderly with cancer, they are quite upright. They want to know what is their longevity and what are the treatment options for them, and then they take an informed decision after consulting with us and also with the family.
Thank you, Dr. Rajiv. We have few questions here which are very patient specific. I don't know whether we will be able to answer in this session. From Mr. Rajagopal about breast cancer, and also Mr. Satyamangalam Bhima Rao about cancer. His sister with cancer after chemotherapy is having nausea and fluid is being filled in her stomach. Please let me know what to do. I think an online chat session here, I think it would be too superficial to address this issue because the doctors nearby should assess and try to see if they can give any relief for her. We are sorry about not being able to take that question, but we can encourage you to approach the specialists or the treating team nearby.
Yep. So I think the question on breast cancer, if a ER/PR HER2 positive, the oncologist mainly targets the HER2 cell when they decide chemotherapy for HER2 positive FCM. So that's
continuous. Yes.
Yeah.
No
so I think it's highly individual specific, and the age and what the patient and family wants, and HER2 positive cancers earlier were considered a very aggressive type with lot of chance of recurrence, but with the advent of anti-HER2 treatment and optimally managing them will make it much more curable, and it's almost like a ER/PR positive cancer. Yeah. And any other individual patient advice or suggestions, please contact our team. We will get back to you in the coming days and see how we can help you. So there's a question from Mr. Madan Mohan. My wife was treated for breast cancer 10 years back and was declared cure. Now she's taking tamoxifen tablet for past 10 years and she's 78-year-old and active. Mr. Madan Mohan, it's very heartening to know that she's doing well after 10 years of treatment of breast cancer, and this is what we have been telling, that optimally treating them will make them long-term survivors. So usually tamoxifen is a drug with very little side effects, but we need to have a checkup once in 6 months with your treating oncologist, and usually 10 years is the time for a adjuvant, that is after surgery tamoxifen is given. So if 10 years are over, please contact your treating oncologist and have a discussion whether she can discontinue tamoxifen, and we wish her all good health. There is a question from Ms. Jayanti. I want to ask for my sister. She's 64-year-old and she has fluid filling in her stomach, nausea and vomiting, and now she's taking chemo but of no use. Now my concern is that vomiting. So apart from giving chemo, we need also be very attentive of the symptom care. So as mentioned, she has vomiting and she cannot eat or drink. So that is where the palliative care team or home care team needs also to be in teaming up with the oncologist and try to provide as much as palliation or comfort care possible, and to look at the nutritional aspect, whether we can actually look at improving her nutrition by other means like tube feeding or parenteral nutrition. So please contact a palliative care team or our home care team for more help for you. Dr. Magesh, we also mentioned it earlier that treating cancer in the elderly is not treating one organ alone affected with cancer, but lot of comorbidities. So what has been your experience when the patients undergo treatment for cancer? The other organs like heart or diabetes or hypertension, which is already they are on treatment, how do they fare, and how often do you watch them and monitor them?
Yes, Dr. Rejiv, it is not that uncommon that the older person has multiple problems, medical problems, and when the cancer diagnosis comes, we have to look after all the problems including cancer. Cancer is looked after by the oncologist, and I remember vividly an elderly teacher, retired teacher, who was having a kind of laryngeal or kind of oral cancer. So அவருக்கு வந்து he is known diabetic lifelong, and இந்த கேன்சர் எவாலுவேஷன் இருக்கும்போது அவர் சன் வந்திருந்தார் கூட வெளிநாட்டிலேருந்து. அப்போது he had கொஞ்சம் breathlessness. பார்த்தா வந்து it's a heart attack. He was having a heart attack simultaneously. Immediately admit பண்ணி cardiologist treatment எல்லாம் பண்ணி stabilize பண்ணுறதுக்கு it took time. So அந்த டைமில் the other medications also had to be adjusted for his diabetes and everything. And it took a few weeks. And on top of the diagnosis and the news of cancer also had upset him. So he had given up. So இது இவ்வளோ பிரச்சனை என்னால் சமாளிக்க முடியுமா at the same time. So when a comorbidity destabilizes, it affects them mentally and psychologically in a big way. So it is very important to have in our team a psychologist and a psychiatrist, which we do have. And in நம்ம ஊரில் வந்து some of the time well-wishers and influencers in the family also act as psychologists, because they open up much more to them and believe them. So the patient's son was very aware, and he kind of got one of his other family friends to speak to his father. ஏன்னா sometimes பசங்க சொல்றது கூட அவனால ஏற்றுக்க முடியல, their mind becomes a bit blank. So after 2 weeks of stabilizing from the heart attack and மற்றவங்க எல்லாம் பேசின பிறகு, இந்த டீம்லேயும் வந்து சைக்காலஜிஸ்ட்லாம் பேசின பிறகு, slowly he accepted that this oral cancer is very curable and treatable. But அவர் ஒரு எஃபர்ட் போடணும். He has to come for radiotherapy for 2 weeks, 3 weeks, stay and get this done. So which family support? So what is sometimes under-recognized is the family
caregiver.
The family, the caregivers around the cancer patient, because they are also under tremendous stress, because whatever is happening in their life, அதை விட்டுட்டு வந்து full time வந்து they have to take care of the person with cancer. So நம்ம ஊரில் we have seen lot of heartwarming stories about families coming around the older person. So that is one big aspect which may not be captured in clinical trials, but I think that is a very important aspect of the older person with cancer, especially when they have at least one family member behind them to back them up, to bring them for treatment, and be with them through this journey of treatment for cancer. And that makes the difference between them having a better quality of life with good cancer treatment or not. So in the example we can say we have seen sometimes heart problem or lung problem, but more so it is the diabetes and hypertension destabilizing. So totally low sugars வர ஆரம்பிச்சிடும். அது வந்து sometimes before first day நம்ம consultation, நம்ம team consultation வரும்போது we try to prevent it here, to kind of anticipate யாருக்கு இந்த மாதிரி ப்ராப்ளம் வரும், how to tailor their medications, so and blood pressure. இது இல்லாமல் வந்து food related issues. So mostly side effects will affect the mouth and gastrointestinal system with the treatment of cancer. So other related comorbidity already அவங்களுக்கு இருக்குன்னா, stomach related issues, that can get upset. But most of these symptoms thankfully கொஞ்சம் நம்மளுக்கு treatment options are there, so we can take care of them. So comorbidities play a huge role, and sometimes cancer treatment actually takes a step back for a week or two until the main comorbidity அவங்க இருக்கிற disease which is destabilized, அதை ட்ரீட் பண்ணி ஸ்டெபிலைஸ் பண்ண பிறகு then we are having to go to the treatment of cancer. So that is very not so uncommon, it happens.
And as you rightly put it, the caregivers burnout is also which we need to be taking care, because the elderly with cancer, continuous care usually by the spouse will make them also, they also have comorbids, and they'll also, we have seen in a case with multiple myeloma, the husband was so much concerned, and finally she did well, but she lost her husband to myocardial infarction. So stress related. So we need to be aware of that and make sure that the caregivers are also absolutely taken care of. So we usually advise even in our system, after the team approach that you mentioned, that you take the help of home nursing and assisted living, so that a break is given to the caregiver also, especially if you have a continuous care at home. That will be a burnout which they also have to be taken care of.
Yes, very important point, Dr. Rejiv, in elderly care is to have adequate support, and definitely the whole family, if they rally behind the older person, we have seen better outcomes.
So I think we have had a very fruitful discussion on managing elderly with cancer, the challenges that we face, and debunking some of the myths like age alone is not a factor. So we should have a balance of treating elderly with cancer adequately under the right team, where we should not only think about oncologist alone, but geriatricians, psycho-oncologist, psychiatrist, clinical pharmacist to look into polypharmacy, a good nursing care, and it should be a 360-degree care where care should not stop at the hospital alone. We should give as much as home visits and also home care, and as required assisted care living. So this is the whole spectrum which we need to look at managing patients in elderly with cancer. I thank each one of the viewers who took their time in this time of World Cancer Day, and I profusely thank Dr. Magesh, our senior geriatrician, who is an integral part of our geriatric oncology team. And as I told, many of the time patients equally look at both of our advices and try to get the optimal treatment for them. So again, I thank each of the team that was included in making this chat session a success, and we hope to continue our work in geriatric oncology and more sessions of interactive sessions like this in the future. Thank you so much, and wishing you a good day ahead.
Thank you.
The way they approach the patient, the way they just put the questions, when it's